So today I'm going to talk about fiber optic intubation. And, this should be something that you have the technique in your head, and when the time arises, you're ready to go. And you want to keep it simple. You don't want to have a real complex technique that has multiple steps and it's going to be challenging to set up and execute. So let's start from the beginning. Here's a picture in the operating room of one of our previous residents with Dr. Wachtel performing fiber optic intubation. And let's get right to it. All right, so here is a quick video. Let me just pull this up. This is a guy named Michael Balin, I think in Harvard or one of the centers, and he definitely deserves Teacher of the Year award for this video. I don't know if any of you have seen it, but the reason I'm showing is it can really exemplify how simple topicalization can be. So the reason we do awake fiber optic intubation is for patients that we're not sure if we can ventilate. So this patient in the picture here, right? This is a very common situation. This is probably some submandibular abscess. And if you induce this patient, you induce them with general anesthesia, and you go to open their mouth and they have trismus and you can't open their mouth, where are you going to go from there, right? And so the key is to not induce this patient. The key is to secure the airway with them spontaneously breathing so you don't have the opportunity to lose the ability to ventilate. So we have difficult to ventilate patients, difficult to intubate patients. If we put someone to sleep and we can't intubate them, but we can ventilate, you're in the non-emergency pathway of the difficult airway algorithm. You could try a different type of blade. You could try your McGrath, you could try your Glide. You can try a Glide assisted fiber optic. A different practitioner can try it. Better positioning. You have time. You put an LMA in, you can wake them back up. So that's difficult to intubate. But difficult to ventilate, now you're in the emergency pathway. So you try oral nasal trumpet, it's not working. You put LMA, it's not working. All of a sudden, you're in the invasive airway part of your algorithm, which means you have to do surgical airway, jet ventilation, and potential surgical airway. So we want to avoid that by not going to sleep. Keep this gentleman spontaneously breathing. Once the tube is in and secured, then go to sleep. So I want to show you this video of Michael Balin and how he really can simplify topicalization. So
needle goes in, we just sit there for a minute, and well, 2 seconds. He'll withdraw bubbles slowly. And then just get the 3 cc's in and pull out. The next thing I'm going to do is I have 5 more cc's of lidocaine, and this will go on the fibroscope. And this way we can spray structures as we see them. Okay, so we saw the cords and sprayed them. And we'll get started again.
So you're gonna certainly on your oral boards, right? So on your oral boards, your examiner will give you a patient who they paint the picture of being difficult to ventilate. And the quickest way to fail your oral boards is to put that patient to sleep. So when in doubt on your oral boards, if ventilation is challenging, be prepared to give your technique for an awake technique. This is a patient of mine with angioedema, right? And you will all be called for this patient. You will all have this patient. You'll be called down to the ER any time of day or night, and the patient will be having their tongue out of their mouth. You'll have to make a decision. Am I going to push some propofol and hope for the best, or am I going to take the safer route, which is to topicalize and do an awake technique? I've been called here at this center 3-4 times already for this scenario. So I just grab the adult fiber optic, run to the ER, topicalize, touch of sedation, and proceed. This is a patient at our facility as well with, status post head and neck cancer, multiple surgeries, flaps, radiation. They came to the operating room for tracheostomy. And as you can see, there is no mouth orifice, right? What's your anesthetic plan here? Say, well, I'll go nasal fiber optic. Well, we have normal tissues in our body before radiation, but after radiation, those tissues change. The elasticity that you have in your tissues, you lose that after radiation, becomes fibrotic. And instead of giving and stretching, tissues tear. So the mucosa becomes very friable. You want to be real careful with any technique you do in someone status post radiation, because once you have bleeding, let's picture I go through her nose, right? So I sedate her, some remifentanil, topicalizer, I go through her nose and I cause bleeding. Where am I going to be? Now I have an airway full of blood with no mouth opening and I can't see with my fiber optic scope. So this particular patient, we chose awake tracheostomy. And the reason is I didn't want to cause bleeding by going through the nose. This is a patient, this poor girl was basically held hostage by her boyfriend, and then after being chased by the police was ejected. And this was the world famous Dr. D here, and Dr. Aronova actually as a resident where we did an awake technique. So, with cervical spine instability, should you do awake fiber optic? And, the reality is the textbooks and the editorials and things, they don't really pin you into a corner and tell you you have to do it one way or the other. Let's say that the general consensus was you have to do all unstable spine fractures as an awake technique, and then you did not do that. You might be held negligent by a jury of your peers if it ever went to trial. And so issues like that in the literature typically allow you to make a decision. Some might suggest in certain situations you're doing awake technique. So why would an awake technique be better than a sleep technique? Well, the answer is all these muscles in your neck, when you're awake, they're protecting the spinal cord because they're all have a tone. But when you induce anesthesia, when you do laryngoscopy, you allow a lot of translation. And if the bony components are unstable, you could potentially have bone hit spinal cord and cause a transection. So sometimes the safest technique is to do an awake technique with an unstable spine. And so how do you make that decision? Well, do they have deficits? You talk to the surgeon, you talk to the spine surgeon, because the spine surgeon knows that fracture. They've looked at the imaging and they say, oh no, this is stable, or no, this is very unstable. I need you to be careful. And then you have to do it one of two ways. General anesthesia with inline stabilization, and some indirect laryngoscopy like a Glidescope with minimal translation. So basically, what is inline stabilization? One of your peers holds the occiput like this. It's not traction, that's been disproven. It's just holding it in place. You're basically countering the forces that the laryngoscopist is doing. So as they lift, which they try not to do in this case, the other person is just holding the head still. And maybe you want to consider not doing cricoid, right? Because if you have an unstable spine and you push down on the cricoid cartilage, you might push the spine into the spinal cord. So sometimes that can be dangerous. So inline stabilization, and then you take that Glidescope and you slip it in the mouth and you try to just get that view without really lifting. Because the reality is Glidescope doesn't remove, it minimizes, but it doesn't remove that cervical spine motion. So you really want to just kind of get it in, get your view, and delicately put the tube in. So that would be going to sleep with inline stabilization, indirect laryngoscopy, minimizing the cervical spine translation versus an awake technique. And now when you do an awake technique for an unstable spine, you topicalize, you get your sedation going, which we're going to talk about. Once the tube is in, because of the remifentanil, patient's not going to be bucking and coughing. They're going to, a lot of times they'll give you a thumbs up and you say, give me a thumbs up, and they do that and say, wow, it's good topicalization, good sedation, because there's no bucking. But you really want to establish that they can move both hands and both feet before you go to sleep. So you say in your notes, because it's all about documentation, topicalization, sedation, awake fiberoptic intubation, patient moved for extremities prior to induction of anesthesia. And so that way you show that there was no injury during your intubation, because there can be injury during position. It always bewilders me when we're so careful with the cervical spine for intubation, and then the surgeon comes in, puts a shoulder roll under, drops the head in extreme extension, tapes the shoulders down. And I'm like, I just spent all this time to minimize any kind of movement, and now we're hyperextended here. And so in those, those situations, sometimes it's good to get post-intubation motor evoked potentials prior to positioning to show that there was no problem from intubation. And sometimes you even do pre-intubation motors. So you put the patient to sleep, put a bite block in, you bag them, you have them check motors, you intubate, check motors again, no change, the problem wasn't from your intubation. So these are all things to talk about. All right, let's get into technique, because we've got a short lecture today. Here is a nebulizer. When you nebulize, the mucosa really responds better to 4% lidocaine rather than 2% lidocaine. So that's pretty clear in the literature that 4% or 5% lidocaine is going to work better on the mucosa than 2%. And when you nebulize, and here's the nebulizer that we're more used to, you want to have the flow only on 6 to 8 liters per minute, because when you go to 15 or 10 from the Christmas tree of oxygen flow, you're making very tiny particles of local anesthetics, and they're going very deep into the lungs. But what do we want to topicalize? We want to topicalize the 9th, V2, 9, and 10, right? And so we're not really worried if the respiratory bronchial is anesthetized. We want the upper airway anesthetized. So you grab a nebulizer like you'd give albuterol. Now this one is showing breathing through the mouth. Sometimes it's better to put a simple mask on, so you also get the nose a little bit as well as the mouth and the larynx. And you put it to 6 to 8, and you put 4 cc's of 4% lidocaine without epinephrine in the chamber. And then you instruct the patient, take some nice deep breaths, and you watch them and make sure that they're topicalizing well. Now you also want to prepare the nose. So even if you're planning on an oral intubation, you want to take some Afrin or oxymetazoline and vasoconstrict the nose, because the last thing you want with a difficult airway is to have bleeding. So even if you're playing on the mouth, grab some Afrin and you tell them to point it at the ipsilateral eye, and you make sure they get a real nasty look on their face like they got enough medication, because sometimes it doesn't come out. First shake it, squirt it in air, make sure you have good aerosol, and then do both sides. And you also want to give glycopyrrolate. So you want to give this glycopyrrolate because it will double the duration of your topicalization. So when you topicalize with lidocaine, it lasts 20 minutes. So if you topicalize in the holding area and it takes you 20 minutes to get in the room, your topicalization is not longer effective. So if you give glycopyrrolate, you'll double that. It'll go to 40 minutes. So you make sure the heart rate's not 160 or whatever, and then you give your 0.1, 0.2 glycopyrrolate. Now, we all know about toxicity with local anesthetics, right? So lidocaine, we typically keep it to 5 milligrams per kilogram. This is what was always taught, 5 milligrams per kilogram of lidocaine without epinephrine, or 7 milligrams, not applying topicalization here, but 7 with epi if you were doing an epidural or something. So that was always ingrained in our minds, 5 milligrams per kilogram of lidocaine without epinephrine. So a 70 kilogram male would be 350 milligrams. Well, the good news is when you topicalize, a lot of the medication does not go into the body. So let's talk about how much you can give and what's safe, so you have an idea in your head how much you can use. Now, the toxic plasma level for reference is 5 micrograms per ml. That's where you might start getting some perioral numbness, some dizziness, some confusion. And at 8 micrograms per ml, you will seize. And at 20, you will die. And the good thing is, if you seize, you're not going to get to the point where you're going to die, because the seizing, that CNS manifestation, is going to make you stop administering the local which is a benefit. But if you have a difficult airway and you're seizing, that is not a good thing. So we want to stay below 8 without question, and certainly below 5 if we can. And I've been in the situation where I've given too much and I had some QRS widening and everything went well, but that made me really study this issue and get to know it. So let's talk about it. When you nebulize, so you put the 4 cc's of 4%. So that's 4% for the medical students here is 4% lidocaine is 40 milligrams per ml. So 4 cc's is 160 milligrams. Half of that is going to go to the atmosphere. It's gone. So don't calculate half of that nebulized dose as part of your total. And then there's a book I have, an Airway book, that basically gave a bunch of examples of how much local they used and what the blood level was. And it really helped me put into perspective how much I can use. So when they took 1.5, these are all different studies, so you'll see some variability here. But when they took 1.5 milligrams per kilogram of lidocaine and they nebulized it, the blood level was 3 mics per ml. So well below toxic level. When they sprayed the larynx, even though they use, so 3 mLs at 10%, that's 300 milligrams, which is close to the 5 mLs per kilo that we talked about as being toxic, only had 2.5 mics per ml. So the laryngeal spraying, the airway spraying, when you spray through an atomizer, very little absorption. Another example of nebulized, they gave 6 milligrams per kilogram. So that should be toxic, but turned out the blood level was extraordinarily low in that study. And that's because half of it was lost to the atmosphere and a lot of it wasn't absorbed that landed on the mucosa. And there's a spray as you go technique. And this is a technique I'm going to teach you. That's where you basically topicalize as you go through. So you have some local on the working channel of the fiber optic scope, and you spray as you go to get the relevant structures. So they gave almost 7 per kilo, and the blood level was only 3.6. But I do want to point out, anything you spray in the trachea is 100% absorbed. It's like giving it IV. So if you do a transtracheal spray, really count that towards your totals and ultimately apply all this information together to come up with a plan. Now, benzocaine spray, you've seen the spray can of benzocaine. Now, the one that's called hurricane spray is a benzocaine tetracaine combination. And I remember going to the cath lab for TE, and the cardio fellow was spraying the pharynx. That is methemoglobinemia waiting to happen. Just get your methylene blue ready and give it. The dose of these sprays are 1-second sprays. So you want to grab the tongue, pull it to the side, see the palatal glossal arch where the 9th nerve is, and do a 1-second spray on each side. Right? So before I have 7 EGDs today, some of the real sick ones, I'll grab their tongue with some gauze, pull it to the side, other side. That will get the 9th nerve, because the 9th nerve is the posterior third of the tongue to the vallecula. That's predominantly your gag, the 9th nerve. So if I can get that palatal glossal arch on each side with a 1-second spray, now I'm going to have to use about 1/3 as much propofol as I would have, because that scope is going to cause the initial gag. So 1-second spray, and always be able to recognize methemoglobinemia if it occurs. All right, now let's get into our technique for the awake fiberoptic intubation. We have the KISS method. The KISS is an acronym for Keep It Simple Stupid, as a design principle noted by the US Navy in the 60s. And so if you have a technique where you do multiple different applications of topicalization, it's going to get time consuming and tricky and complicated. So let's keep it simple. So patients in holding area, you're about to go in the room. You put an E-cylinder on the bed, you hook it up to the simple face mask on a nebulizer. You go to 6 liters per minute. You've given your Afrin and your glycopyrrolate, and you give 4 mLs of 4% lidocaine. If you ever can't find this, it's usually an endoscopy Omnicell, or you can call pharmacy directly. And we have 4 and 5% at the hospital. Opt for 4. 4 works better than 2%. So if you put 2%, the lidocaine that's in our draw, in the nebulizer, it will not be effective. You need 4%. And then I'll put 4 mLs, 5 mLs of 2 or 4% on the working channel of the fibroscope. So I've topicalized, right? It's gone in the nose. It's gone. The big droplets landed on the palatoglossal arches. They landed on the vocal cords. They've inhaled it. Some of it got to the proximal trachea. But still, before I go through the cords, I want to give them a spray. So I have that syringe on there. So I go in the mouth, I see the cords, and I empty my syringe. Now, the transtracheal injection I've done several times. It's a good option. You saw it on the video. So one pointer is when you feel your cricothyroid membrane, don't take your hands off and then put the needle through. Keep your hands there and go between your two fingers. You very easily could lose sight of the midline. So keep your fingers there. You feel the thyroid cartilage, the big one. You walk off it into the cricothyroid membrane. You put your needle through. And what needle is that? You can grab an angiocath. You can grab a 20 gauge angiocath. You can put the angiocath on a 10 cc empty syringe. I'm sorry, with a few cc's of saline. You go through and you aspirate. When you see bubbles, you slide the catheter in. You take the syringe and the needle out. And now you have a intratracheal catheter and you spray your local. Now, how do you spray your local? First, you have them inhale deeply, right? So they inhale deeply, then you spray, and then they'll cough it up because you want to bring the local up to the cords, up to the mouth, the higher end of the trachea. If they exhale and you spray, they're going to breathe the local down here. That might be good for bronchoscopy, like a pulmonologist would want to do, but we want up here. So we want to have them inhale, then spray, and then they'll cough it up. Now, you wouldn't want to do this on a patient who has intracranial hemorrhage or elevated ICP, where coughing would be of consequence, very unstable spine. So this is more for that abscess guy. All right, so what nerves are we dealing with? Well, primarily we have trigeminal for the nose, so V2 branch. We have glossopharyngeal for the posterior third of the tongue. Remember, the front of the tongue is facial nerve. Hypoglossal moves the tongue. Front of the nerve sensory is facial nerve. But we don't care about touching. We care about the gag reflex, and that is the glossopharyngeal nerve. So the posterior third of the tongue to the vallecula, which if you look at the yellow, that's where you put your blade. So if you're going to do an awake look on someone, it's very important to have the ninth nerve, because the afferent sensory from the posterior third of the tongue to the vallecula is the ninth nerve. The motor limb is the 10th nerve. That's the coughing and the gagging, but the sensory limb is the ninth nerve. So you want to get that. How do you get that? There's a lot of ways. I'm going to talk about them. And the last is the vagus nerve. So the pink is the vagus nerve, and that is primarily in the form of the intrinsic branch of the superior laryngeal nerve, which is the basically top of the cords, and then the recurrent laryngeal nerve, right? So the vagus nerve comes out of the brain, and then it gives off the recurrent, goes under the aorta or the subclavian, depending on the side, and it goes into the internal and external branch innervating muscle, and the internal branch innervating the top of the cords. And then the vagus nerve also gives a recurrent laryngeal, which is the lining of the trachea as well as the bottom of the larynx. So here's a look at the nose, right? So where are we putting our tube when we go through the nose? We're going under the inferior turbinate. And the blood supply is very prominent. There's the anterior ethmoid artery, which is off the internal carotid. There's sphenopalatine branch off the external carotid. And so topicalization with oxymetazoline is really going to vasoconstrict these guys and minimize bleeding. Another tip to minimize bleeding is to take a nasal trumpet, a small one, like a 28. All right, so how do I topicalize the nose? I take a long Q-tip, like a culture swab, basically, put it in lidocaine jelly or 4% lidocaine, put it in the vestibule of the nose. Take it out, dip it in again, a little bit deeper, take it out, a little deeper. And this is all while they have remifentanil running. And then I get until I'm all the way back by the sphenopalatine ganglia. That's how you topicalize the nose. Then you take like a 28 nasal trumpet. And by the way, in the holding area, you want to confirm which side is more open. My right nostril is more open. So that's because it alternates throughout the day, vasoconstricting, vasodilation of which side is more open. So figure out which side is more open, topicalize both sides. But I'm sorry, topicalize vasoconstrict both sides, but topicalize the side you're going to go after. And then after you've gone in with your Q-tip, take a trumpet, dip it in the lidocaine, and insert it. And that will kind of pre-dilate or open the space before you put this very rigid endotracheal tube in. So you say, oh, the 28 went in real easy, maybe then put a 30, 32. And now that is, you know that when you go in, you're not going to do a turbinectomy and basically cause bleeding in this difficult airway that you have. Because you may choose to go orally if the nose is really tight. Now, nerve-wise, I want to point out this sphenopalatine ganglia, which is basically a parasympathetic ganglion, but really trigeminal V2 is the major sensory piece. But this is all taken care of with the lidocaine. And it's slightly caudal, it's 20 degrees. You're kind of aiming down as you go in, and with the endotracheal tube. Here's a topicalization technique. I typically don't go up like this. I'll just work my way back. But the goal is to be able to hub that thing without any kind of wincing. All right, so we talked in depth about the vagus nerve. Now let's talk about the superior laryngeal nerve aspect of it. So you can see we have the superior laryngeal nerve, we have the external branch and the internal branch. The external branch is the smaller branch and it supplies the cricothyroid muscle. All the other muscles of the larynx are innervated by the recurrent laryngeal. The external branch functions to tense the cords by activating the cricothyroid muscle, increasing pitch. This is damaged a lot in thyroid and parathyroid surgery, and they would have troubles with phonation. The internal branch is a sensory branch. Our sensory branches are distributed to the epiglottis, base of the tongue, supply the mucous membrane surrounding the entrance to the larynx, and the mucus lining of the larynx as far down as vocal cords. So if you swallow the wrong way and you cough like crazy, that's the reason for that is the sensory information that's going to the brain from this nerve, as well as the recurrent. So we want to topicalize that before we go through it with our endotracheal tube or fibroscope. Okay, so we're going to topicalize one nerve at a time. We've already talked about V2. So let's talk about how do we topicalize the superior laryngeal nerve. Well, the topicalization via nebulizer is going to be a big piece of it. This is another option. These are called Jackson forceps. I don't advocate this technique, but I just want to kind of show you how different ways to do it. One way is to put a pledget on a Jackson forceps soaked in 4% and reach down there. I don't do this. Another way is to put some 4% lidocaine in a 10 cc syringe. Put a 20 gauge angiocath on the end of the syringe without the needle. Grab the tongue and drip it on the posterior third of the tongue. So it drips down the tongue and it goes to the area that gets where this area is. Again, that one's more glossopharyngeal, that technique. And some people will even paint the posterior third of the tongue with the, there's like a lidocaine paste that they use. But I don't get into all that because we want to keep it simple. So the way I topicalize the superior laryngeal nerve is I directly spray it through the fibroscope when I see the cords. For your boards, and I've done this here and there. I remember doing it with Dr. Comer in the St. Michael ICU about, let's see, 13 years ago. Is you feel the hyoid bone, right? So above the thyroid cartilage, you got the hyoid bone, you feel the greater cornu. And right below it, you go in with a small needle and you feel a pop as you go through the thyrohyoid membrane, and you inject 5 mLs on the way out, and that will get the superior laryngeal nerve. But honestly, if you have a fibroscope, you just spray through the working channel when you see the cords. That's your best bet. But this might be for a technique of, let's say you're going to do like a wake look with a Glidescope. You might topicalize glossopharyngeal, like I taught you, and then do this external technique. So when you put the tube through the cords, they don't buck a lot. All right, so that's superior laryngeal nerve. It can be blocked with nebulization, direct spraying through the fiberoptic scope, Jackson forceps soaked pledgets, or an external technique with a needle. Nobody really likes needle techniques like that though, because you could get bleeding and patients don't love it, etc. Things like that. Okay, so that's supralaryngeal. Let's talk about glossopharyngeal. So the ninth nerve, the sensory limb is mediated through the ninth glossopharyngeal nerve and the motor limb through the 10th vagus nerve. The technique, you take a long needle. See, they're pushing the tongue out of the way with a tongue depressor, or you can grab the tongue with a piece of gauze. And you want to go, you see the palatal glossal arch, right? So the arch from the glossus, the tongue, to the palate. At the base of that is a good spot to put 3-4 mLs, they say 5 here, of local anesthetic, whatever local anesthetic, 1%, 0.5%, 2% lidocaine. This is an injection technique, so it doesn't have to work mucosally. So you would not use 4% here, because that will just use up part of your aliquot of what you're allowed to use without getting any benefit over 2%. So 1 or 2% lidocaine, palatal glossal arch, and this will allow you to accept the laryngoscopy and also prevent gagging as the scope is going in the mouth. Now that is the ninth nerve and the superior laryngeal nerve. Now let's talk about the recurrent laryngeal nerve. Now there's a lot of techniques. I know Mekian likes to put an epidural catheter through his fibroscope. And when he sees the trachea, he advances it down the trachea and he squirts through the epidural catheter to get the recurrent laryngeal. That's one option. Another option is to spray directly, which is what I do. Another option is to do transtracheal injection. So this is a technique where you feel your cricothyroid membrane, you put a needle in, you aspirate, you see bubbles, you have the patient inhale deeply, and then you inject 3-4 cc's. So this is the recurrent laryngeal nerve. It's a branch of the vagus nerve that supplies the intrinsic muscles of the larynx. So the recurrent laryngeal gets the intrinsic muscles of the larynx versus the superior laryngeal external branch gets the cricothyroid muscle, which tensions the vocal cords, and supplies sensation to the larynx below the vocal cords and branches to the trachea, esophagus, and pure constrictor muscles. You can also use this opportunity if you have a very bad airway and you anticipate you may have to do a surgical airway. This is a great time to leave an angiocatheter in the trachea. So at a later time, I have this tray here. It's an emergency cricothyroid tray. There you go. It's a Seldinger tray. So what is a Seldinger tray? Seldinger means that you have a lumen, you put a wire in it, like we do central lines, then you make a skin nick, dilate, and put the device in. So that's Seldinger. So Melker was a pediatric cardiologist who designed this. And so a lot of times you'll see it called a Melker cricothyroidotomy tray. And a lot of times you'll see Seldinger tray like this one. This one's made by, Melker Universal, go figure, okay. So basically, if you have an angiocatheter in your cricothyroid membrane and it fits the wire, make sure you don't put a 22 gauge angiocatheter. It would have to be like a 16. If the airway is really bad and you say this might turn into a surgical airway, you could put the angiocatheter in, slide it in, put your local that topicalizes. And now if you got into trouble above, you could always put a wire through there and you've already had that area set. So never done that, but just a point that I've heard at a few airway conferences over the years. All right, let's talk about our equipment. Now this lecture is going to be recorded and posted on our YouTube channel. So if you guys have to go set up your room, do not feel bad. As we get towards 7:10 here, you can always watch it starting tomorrow once it's up. All right, so fibroscopes are different sizes. There's neonatal, which is like a piece of spaghetti. There's 4 millimeter pediatric. That's the one we have laying around the operating room. That's the one we use for our double lumen tubes. And then we have our 6 millimeter adult scope. The 6 millimeter adult scope is what you see in the bronchoscopy labs that the pulmonologists use. And it is what I personally use for all my awake fiber optics because it's like driving a car. Pediatric scope, you go in, it's a little flimsy, it gets dirty, you have to keep cleaning the lens. The adult scope is such a better experience and it makes this very simple. Now, when I was a resident, I complicated awake fiber optics. Said, oh, I hope I can get it in. It's so complicated, topicalization. Now I keep it simple. Topicalize with a neb, put the local on my working channel. I go in the mouth and I go down to trachea, right? It's not that tricky. Mouth, trachea. We're not making the left turn, a right turn, going up different lobes of the lung. We just got to go from the mouth to the trachea. So as long as you're topicalized and appropriately sedated, it can be a very successful venture. So when you can, say, hey, we have this difficult airway. Can we use the adult fiber optic scope? And you may have to call endoscopy to bring it up because we don't have it in the main OR. But listen, you're the physician. You have a patient with a need. If you feel it's appropriate to use the adult scope, you demand it. You say, listen, because the surgical techs and the team that gets the room ready, they have the ability to get whatever equipment they need. So you say, listen, we need the adult fiber optic scope for this case, and that's it. But be aware it has to be processed correctly. So you don't want to just use it and leave it out till Monday when all the secretions dry on the inside and then they have to go get it gas cleaned commercially. You have to make sure it's processed. So they have a technique where they first put enzymatic cleaner through the working channel, and then they have different ways to sterilize it. So never just use it and then leave it till Monday, because then you'll never be allowed to use it again, because they'll say, no, you lost the opportunity now because we had to do a $2,000 repair. All right, so request an adult scope when you can. That's a 6 millimeter fiber optic scope. Here's the parts. We have the light source coming in. We have a suction port, which, by the way, you can also put oxygen through. If there's oxygen coming out the suction port, it's going to keep the lens a little cleaner. It's also going to keep them, even when they're apneic, it's going to keep them better oxygenated. Try not to get apneic, by the way. And then we have the working channel. And be aware there's like a connector piece that after the scope is cleaned, you have to attach screws into. We have a focusing ring and our flexion lever. And now the flexion lever makes the tip of the scope go down and up. So if you're holding the scope upside down, then down is up is down. So before you enter the patient, make sure that you practice to show which way is up and down. Also, look at the video screen. Make sure on the video screen that up is up. I did a double lumen yesterday, and the camera head was clearly upside down because when I went in, right looked left, left looked right, but I saw the tracheal rings on the bottom, so I knew that the membranous side up top was actually the bottom. So I rotated the camera, had the membranous side, the tracheal rings, and now right was right and left was left, and I was down the left, and everything was good. By the way, I did a rector spinae block on that open thoracotomy and zero pain. Very effective. Okay, fiber optic tips. You have to tell your patient what's going to happen. If you just bring them in the room and start shoving a tube down their throat, they're going to fight you. If they understand, hey, listen, you have this abscess, and if we put you to sleep the traditional way, we could have a problem breathing for you. So instead, we're going to sedate you, make you comfortable. We're going to make everything numb like a dentist would numb your teeth. We're going to numb everything, and we're going to put this tube in with you a little bit awake to keep you safe. If they understand that, it's going to be a lot less of like, what are you doing? Pull the scope out. What are you doing? Now they shouldn't be awake enough to do that, but patient expectations lead to success. Assess the more patent nostril in the holding area. Breathe through each nostril, see which side's more open, and then go after that nostril. Nasal is more uncomfortable, but there's less gag. So if you don't feel topicalization is great, nasal is important. Now, there's other times when nasal is good, like the surgeries in the mouth or something like that. But I typically go through the mouth because they're usually for abscesses and tracheal tumors and things like that. A deep breath adducts the cords. So it moves the epiglottis forward. So when you're going in, when you see the cords, you spray them. Now, when you spray the cords, they're going to cough a little bit. Hopefully not too much because the remifentanil is running, but they're going to cough a little bit. And you may have to just wait a few seconds for that to settle down. But then before you go through the cords, you say, take a deep breath. And as they take a deep breath, the cords open up, and then you enter. You could put O2 through the working channel. You're going to go in through the mouth. You're going to see the uvula. You're going to go around the tongue. You can see the cords. You're going to spray the cords. You're going to go down the trachea. Largest bronchoscope possible should be used. If you have someone pull the jaw forward, it'll help you get more space back there, and you'll see a little bit. Moderate to severe bleeding occurs in almost 1 in 10 patients, so be ready for that. And overall, in the literature, the success rate is 72%. What does that tell you? That means 1/3 of the time you're not going to be able to do it. And again, that's looking at all comers, people less facile with it. I don't think it number has to be that low, but you always have to have plans B, C, and D. And a lot of times the end of your plan is, especially at Joe's, you have a trauma surgeon say, hey, listen, I'm about to do some awake fiber optic on this difficult abscessed airway. Can you be available in case I lose the airway, where you could do invasive surgical airway? But me at a community hospital today, if I get to the emergency pathway, there's nobody else to call. I'm doing like let's say urology case, it's 2 a.m. I need surgical airway access. I'm doing it. And the way to do it is to feel the thyroid cartilage, put a knife on, enter the cricothyroid membrane, stick a Kelly in, spread it, and put a 5 tube in. Or for me, I would use the Melker cricothyrotomy tray because we're good at central lines. The Melker cricothyrotomy tray is just like putting a central line in. All right, this is called a Williams airway. And what the Williams airway does is it's like protects the scope from the patient biting the scope. But I want to warn you that you want to make sure the endotracheal tube is the right size for the Williams airway you're going to use. So before you start, make sure that the tube fits through the Williams airway, because they come in different sizes, and you wouldn't want to have your tube not fit through once your fibroscope's already in the trachea. Some people also will cut their nasal trumpet. Now, when you go through the nose, a lot of times your scope gets all dirty. So if you went through a nasal trumpet, you might protect the lens from getting covered in blood and secretions. And then when you're down the trachea, you could just pull it out. So they'll cut their nasal trumpet. Again, I frequently go through the mouth, but if you do nose, that's an option. Now, you could stand behind the patient, or you could stand in front of the patient. And traditionally, people stand behind, but I do not. I stand in front. And the reason is, if you see from the back, you have to make an S curve with your fibroscope. But from the front, it's only a C. So I will actually come in the room and I will stand in front of the patient. And I'll fiber optic them from the front, and I only have to make a C. Versus if I'm behind them, I have to make an S. So I'll sit the patient up, patient sitting up, sedation's going, they're already topicalized, and I'll enter from the front and go from there. All right, so we go in the mouth. We see the camera marker of the camera head is at the top of the screen, and we see the uvula. We go a little deeper, we see the epiglottis. We navigate like a video game until we see the cords, and we spray the cords. Now, sometimes you'll put your fibroscope in and everything will be perfect. And you're like, I'm all set. And then you'll go to advance your tube and it will get caught up. And this might happen for your tube exchanges on the floor as well. And what you want to do here is pull your tube back a millimeter or two and rotate it 15, 30 degrees and try to advance it again. Because a lot of times it's just caught up on the arytenoids. Now, we have a tube, Georgina brought it for us, helped us order it. It's called the Parker tube. And the Parker tube hugs the fibroscope. So you see how this part in A would get caught up on the cords? The Parker tube will stick to the fiber optic scope and allow it to enter easily. So whenever I have the option, I will always use a Parker tube for my fiber optic intubation. So you want to have your tube loaded on the fibroscope. You bring it all the way to the top of the fibroscope. You can put a little piece of silk tape to hold it there. Usually you don't have the end piece on, you have that on the side, but make sure you have it available because you will need it. And then here's an example of how the bigger scope will prevent that hanging up, right? The little scope, the pediatric 4mm scope versus the adult 6mm scope, there's less likelihood for this rim of the endotracheal tube to get caught on the cords. And one point I really want to drive home today is this basically technique where you cheat. So you go to intubate and you can't see anything. You're ventilating okay. Everyone comes in the room, or let's say you're called in the room, right? You can really be the hero. You grab the fiber optic scope, put the endotracheal tube on it, You put the Glidescope in the mouth, right? So the Glidescope goes down the center of the tongue. The McGrath sweeps the tongue, but the Glidescope goes down the center of the tongue. You lift up to get the best possible view. Then you let someone else hold that scope. So you hand off the scope. That scope is now in, the tongue is out of the way. You still don't have a view because it's a difficult airway. But then you hug the Glidescope with the Fiberscope, and that will allow you whatever motion you need to finally see those chords. So this is a Glidescope Assisted Fiberoptic Bronchoscope intubation. And this is a hybrid technique. And it's only possible now because we have these indirect laryngoscopies. And what this does for you is it takes away all the tongue and everything that's on the back of the pharynx that's preventing you from getting a good view. All right, let's focus on sedation a little bit. So my choice is remifentanil. I take 2 milligrams of remifentanil in a 250 ml bag of saline, and I put it on a pump. The reason I put a low dose in a high volume is I want a very high rate going into the patient so it doesn't collect in the IV tubing. It's just constantly pushing in. If someone goes to give some Versed, they don't push in a bunch of high concentration remifentanil. It's not going to get me into trouble. Or if someone closed the IV and I didn't realize it, it's not going to all collect in the tubing. And then all of a sudden I have an apneic patient with a tracheal tumor. So I will get the remifentanil going at 0.05 mics per kilo per minute. And then I'll go up by 0.025 mics per kilo per minute every couple of minutes until I see a couple things. You want to do a opioid sedation scale, right? The POSS, P-O-S-S, Passero opioid sedation scale. A 1 is me right now. A 2 is the eyes are closed, but you call their name and they wake up and they stay awake. And a 3 is their eyes are closed, you call it, hey, and then they kind of close their eyes again. So you want to go from a 2 to a 3. That's kind of your endpoint for your fiber optic intubation. You want your end tidal on the screen to go from a respiratory rate of, say, 14 down to maybe 8 to 10 or 6. Whatever it is, the lower the respiratory rate, the more likely you'll be able to not have gagging, and they'll tolerate the intubation. So we'd start our remifentanil at 0.05 mics per kilo per minute. We go up by 0.025 mics per kilo per minute until we get to our endpoint, which is a respiratory rate 6 to 8. Patient is a POS 2 to 3. Maybe in that time I've titrated in some midazolam, 0.5 milligram at a time, 1 milligram at a time, but not so much where I'm going to lose cooperativeness. So I look at the patient, they've been topicalized. So they had their neb, 4%, 4 cc's of lidocaine at 6 to 8 liters per minute. That's completely gone in. Maybe I'll assess gagging by putting a Yankauer in before I start. So let's say I have my remifentanil running. I'm at like 0.1 mics per kilo per minute. Respiratory rate is 8. Topicalization is done. I'll put the Yankauer in, and if they gag, I might say, I have to go up on my Remi. Or maybe I have to topicalize better. Maybe I'll take a tongue depressor, wrap some gauze around it, soak it in 4% lidocaine, and put it in so it they kind of gag on it, which shows that it's on the right spot that causes a gag, the 9th nerve, and let that kick in a little bit. Or maybe I'll pull the tongue out and drip a little 4% lidocaine out of an angiocath on the posterior third of the tongue. But once the gag is gone and they're well sedated, you enter the mouth with the fiberscope, you see the chords, and that's when you spray your last couple cc's of 4% lidocaine through the working channel. Then you have them take a deep breath. The fiberscope goes through the vocal cords. Now you'll see the carina. My advice to you is to keep your eye on the carina as you advance the tube. So a lot of people will see the carina, look at the tube, and as they're going in, they're accidentally pulling the scope out and the tube doesn't go in. So my advice to you is, once you see the carina, keep your eyes on the video screen. Keep the carina in view the whole time, and have you or someone else advance the tube and see that the tube is not down the main stem. Because the last thing you want to do with a difficult airway in the middle of the case is pull the tube back, because you might pull it out. So if you have the carina in view, your endotracheal tube is in, you'll accomplish 2 things. You won't accidentally pull your scope out, and you won't accidentally be endobronchial. So your tube comes off of the fibroscope. Do you push propofol? Not yet. Next, you put the cuff in the air in the cuff, hook up your circuit, and squeeze the bag. Make sure that you have a seal, your balloon isn't ruptured, and that you have end-tidal. Once you have those things, I'll usually ask the patient to give me a thumbs up to show everyone how great the topicalization was, and then we'll push our propofol to induce. Now remember, extubation has the same problems that intubation had as far as ventilation. So don't extubate unless you're confident that the patient's going to be able to maintain. And there are all techniques where you leave a catheter in the trachea as you remove the endotracheal tube in case you had to emergency reintubate, or maybe you'll extubate with a surgeon who's ready to do cricothyrotomy if there's failure. Always have plans for extubation. You know, even with the very obese patients, if we take a bariatric patient, it's usually pretty reasonable to get the tube in. With our Glidescopes and our McGraths, optimal positioning, ramping, 2 practitioners at the head of the bed, straps, airways, we're usually able to mask, we're usually able to intubate. But I'm willing to say that in the very obese patient, more poor outcomes occur on extubation than intubation, because the obstructive sleep apnea is so severe that when you extubate, the residual anesthetics lead to inappropriate reaction to carbon dioxide as well as decreased pharyngeal tone, and they fail frequently. So make sure for your extubations of your obese patients, fully awake, sitting up, great tidal volumes, carbon dioxide is controlled. And then after extubation, make sure you have non-invasive positive pressure ventilation available in the PACU, and don't leave that operating room for 5 full minutes. Watch the patient for 5 minutes breathing on the stretcher or on the OR bed prior to going to PACU. Because what we've noticed is that a lot of reintubations occur in these obese patients in the PACU. And in the PACU, you don't have your machine there. You don't have all your blades and tools and drugs. The patient's probably hypercarbic and flailing around as now as the foot of the bed instead of the head of the bed. So you're much better off reintubating in the operating room than in the recovery room. So a lot of big centers now have policy that you stay in the operating room until you're sure that the patient is exchanging well and they're not becoming hypercarbic and that they don't need some BiPAP. So how do you tell if they need BiPAP? You'll put the mask on them. You'll spontaneously breathe, you'll watch their tidal volumes. Then you'll close your pop off and slowly go up to 5, 10, that's CPAP. And if you notice their volumes are much better, then give them 10 of CPAP in recovery. Or if you notice that you have to give a little positive inspiratory pressure to get a good volume, well, that's BiPAP. So maybe figure out what is the optimal setting there and call a respiratory to bring down the BiPAP to have that for them in recovery. And that will be a bridge as the anesthetics wear off for them to maintain their carbon dioxide. Because once they get very hypercarbic, they become more sedated. Once they become more sedated, they become less cooperative. And all of a sudden you have a flailing, hypercarbic, hypoxic patient who needs to be reintubated. I want to avoid that. All right, so feel free to email me questions. And this is a 2-part lecture. This is on the fiberoptic bronchoscopy, awake intubation. But I also want you to review the lecture on the ASA's difficult airway algorithm, because that helps you recognize who you need to perform this technique on. All right, guys, thanks very much, and we'll talk soon.